like to start by thanking Befusen for giving me the opportunity to present my PhD project here at the Hot Topic session. My name is Greta Snellman and I'm a resident in orthopedic surgery at the Uppsala University Hospital. My PhD project is, the aim of my PhD project is to try to find out more about the association between vitamin D and bone. Even though my studies may not have a direct clinical implication for US orthopedic surgeons, I hope I can make you aware and interested about what's going on within this field. So even though vitamin D is primarily associated with rickets and osteoporosis, it has lately been shown that vitamin deficiency is also associated with many other medical conditions such as cancers and cardiovascular diseases. Deficiency has also been shown to decrease muscle strength and thereby increasing the risk of fall and fracture. Short on vitamin D metabolism. The main source of vitamin D for humans is the dermal production in the skin. And spending 15 minutes outside in summertime in Sweden will provide you with as much vitamin D as you'll get from drinking approximately 20 liters of milk. But you can also get vitamin D from dietary sources such as fatty fish and fortified dairy products. So vitamin D is further hydroxylated in the liver to a form called 25-hydroxyvitamin D. And this is metabolically inactive, but we can store this form in our body fat and it can be mobilized during periods of lower sun exposure or low dietary intake. And it is therefore the analyzed indicator of vitamin D status. This form is further activated in the kidneys and can then activate vitamin D receptors that are found in many different tissues in the body, but one being the calcium channels in our intestines, and thereby increasing our capacity to absorb calcium from the diet. And as you probably know, calcium is needed for mineralization of our bone tissue. If calcium levels in the blood drop, parathyroid hormone will stimulate the formation of more active vitamin D. But if we have a vitamin D deficiency, the parathyroid hormone will activate the osteoclasts to resorb calcium from the skeleton and in the long run making it weaker and easier to break. So numerous assays are available for, I also want to say that when I talk about vitamin D in my presentation, it is this form I'm referring to. So there are many available assays for analysis of 25-hydroxyvitamin D. Results from studies investigating vitamin D status between relatively homogeneous populations are inconsistent. And we hypothesize that this inconsistency could be due to inter-assay disagreement. So in my first study, we compared 3 commercially available assays to see if they differ a lot. The first assay, an HPLC assay, was performed in a research lab in Norway. And the second assay is, the reassay is a method used at a research lab in Uppsala. And the last CLIA assay is, at that time, about 2 years ago, the standard method used at Uppsala University Hospital's laboratory. We analyzed 204 serum samples with all these 3 methods. And our results show that independent of season, the HPLC assay results are about 25 nanomoles higher than the assay used at the Uppsala University Hospital laboratory. And if we analyze the serum samples that were drawn in summer and winter separately, these differences persisted. So in this population, if we send these serum samples to the hospital lab, that is this lab, they will actually say that 40% of, or more than 40% of this population are vitamin D deficient. But if we send it to the research lab in Norway, they will say that approximately only 8% have a vitamin deficiency. So the conclusion of this is that there are great inter-assay disagreement, and this may be, of course, a very big problem and making it very hard to compare studies on vitamin D if we look at vitamin D and the risk of fracture and osteoporosis, because these results from different studies are very inconsistent. The HPLC method have lately been considered as an unofficial golden standard for the analysis of 25-hydroxyvitamin D. So using this HPLC assay, we tried to find at which level low vitamin D levels are associated with an increased risk of fracture. And we looked at 1,200 Swedish men in the Ulsam cohort, and all fractures that occurred in this cohort during the 11 years that they were followed were registered. And all men that were alive at the end of the study, almost all men, underwent a DEXA scan. And we can see that men who have levels below 40 nanomoles have a modest increased risk for fracture. This is any kind of fracture. It was too few hip fractures to look separately on that kind of fracture. So they have a modest increased risk of fracture with a hazard ratio of 1.65. But only 5% of this population had lower levels below 40, and only 3% of the fractures could actually be attributable to low vitamin D levels. Levels below 40 was also associated with a decreased bone mineral density in spine among these men, but otherwise we did not get any statistically significant decrease in bone mineral density. So what do we actually know about vitamin D and bone? Well, there are several randomized controlled trials who have looked at supplementation with vitamin D and calcium in combination, mostly among postmenopausal populations. Studies on younger women and men are very few. If we look at this meta-analysis that are made, they've looked at populations with postmenopausal women. You can actually see a benefit for treatment compared to placebo. But this positive effect probably is only women living in nursing homes that have a benefit from getting vitamin D and calcium, since if this group is excluded, the positive effect disappears. This year it has actually been published a study where they've given a high dose of oral vitamin D and compare that with placebo, and this is also a group of postmenopausal women. And this study actually shows an increased risk of both fall and fracture among the treated group compared with placebo, even though, as you can see, for fractures, this difference is not significant. When it comes to how our diet and dietary intake of vitamin D affects the risk of osteoporosis and fracture, much less is known. We therefore try to find out more about this association by sending repeated food frequency questionnaires to a large group of Swedish women, and we also registered all fractures that occurred in this population. This study was done in the Swedish Mammography cohort that started in 1987, when all women born between 1914 and 1948 received a food frequency questionnaire, and over 60,000 responded and formed the baseline cohort. 10 years later, they received the same questionnaire again, and we could therefore calculate the amount of vitamin D from food that these women got. All fractures that occurred from start until 2008 are registered, and the amount of fractures were, I think, 25,000. A sub-cohort of 5,000 women also had a DEXA scan, but I don't have the results of these DEXA scans yet. And these results are preliminary, but we can conclude that the risk of any first-time fracture increases if you have a dietary intake of less than approximately 3.4 micrograms a day. And the recommended level in Sweden today is 10 micrograms for adults. 90% in this population had levels less than this. If we look separately at only hip fractures, it occurred, we had approximately 4,000 fractures, hip fractures in this population. The results are about the same. And we don't seem to have a decreased risk for fracture if you, if you have a higher intake. The risk doesn't decrease here, but it increases if you have an intake less than about 3.6. So my take-home message to you is that measuring vitamin D is intricate, and inter-acid disagreement may or probably hamper research results. So you should keep that in mind if you really study on vitamin D and the risk of osteoporosis and fracture. You can't compare two studies without looking at what assay that is used. And vitamin D deficiency does not seem to be a major cause of osteoporosis or fracture among Swedish men. And I don't think that you need to give vitamin D substitution to adults and elderly in Sweden, but it may have a positive effect on defined risk groups, such as those with very low dietary intake or those who are seldom exposed to sunlight.